Everyone. I was just about to say, we're about to press record. The only thing that you will see in the recording is the speakers and panelists, because this is a webinar. So we'll be recording this and uploading it to our YouTube channel so that people can benefit from hearing the speakers after the event. So good morning, everybody, and a warm welcome from Maternity Action. I'm very pleased to be chairing this webinar. My name's Judith Dennis and I'm the head of policy here. I'm just going to do a bit of housekeeping before I actually introduce the speakers. As it's a webinar, the question session will be run by participants submitting questions through the Q&A function. So hopefully everybody's familiar with Zoom. You have to go to more to select the Q&A session, and then you can type your questions into the chat. And we're joined by a member of our NHS charging team who's going to help with that. We're also joined by Lauren, who's helping to run the session. She's the official host, and will help with showing the video that we're going to show later. If you do need to get hold of us during the meeting for any other reason, you can use the chat function and select host and panelists. And Lauren will take an initial look at that and let us know if there's something that we need to address. But hopefully everything will go smoothly. So again, welcome to this launch of the Obstetricians Guide. I'm going to hand over in a couple of minutes to my colleague, Catherine Pellegrino, who's written the guide and who can explain a little bit about the context in which this guide has been produced. So we'll hear from her about how we hope this is going to be used and how this has come about. We're then going to hear from Emily Lewis, who's the Senior Policy and Public Affairs Officer at the Royal College of Obstetricians and Gynecologists, and who's worked in partnership with us on this guide and on the charging work. And so she'll be speaking about their work on NHS charging. Then we're going to hear from Dr. Brenda Kelly, whose title I'm going to have to read out because it's so long. He's a consultant obstetrician and clinical lead of the Oxford Rose Clinic at Oxford University Hospital's NHS Foundation Trust. Brenda's going to share with us her experience of working at the Trust to improve policy and practice in this area. And then just before the Q&A session, we're going to hear from a woman who's been affected by charging. She's been supported to make a film of her experiences. So it's an interview with her, and she's called Mary in the film. And she has worked in the project with Catherine to explain the impact of the charging regime on their health and well-being and that of their child. I'll leave that to speak for itself, and we can people can ask questions about it during the Q&A session. These videos that we've made are on our website, and they've been kindly funded. The production of them has been kindly funded by the Rosa Voices from the Frontline Fund, which is helping to bring women's voices into policy discussions. So we're very grateful for that. And then, as I say, we'll have a Q&A session at the end, and I'll remind you how to put the questions in for that using the Q&A function just before it starts. Okay, so I'm going to hand over now to Catherine, who's going to talk about the production of the guide and our policy work in this area.
Hi there. Yeah, my name's Kat. I'm Senior Policy Officer working on NHS charging here at Maternity Action. I apologise for being practically a silhouette today. I have children in all the other rooms of the house, so this is literally the only place I can go, so apologies for that. I will get one of those ring light things that social media people have to improve that situation next time. Yeah, so before I introduce the guide, I'd like to mention our Maternity Care Access Advice Service, which sees approximately 600 women per year with roughly 100 casework clients. So our team of legal advisors have been offering support and legal representation to women who have been charged for their maternity care since 2019. And from our casework, we know that many women get wrongly charged for their care because either their immigration status has not been correctly identified, or they should have been exempt from the charges because of their experiences of domestic abuse, sexual violence, FGM, or torture. Many women we see who get charged for their care simply have no means whatsoever to pay back the debt, which can be £7,000 and upwards, because they have no income or assessed as destitute. And many of the women we see are either low income, no income, or destitute, and sometimes even street homeless. Women often describe their reactions to receiving bills for their maternity care in terms of shock and bewilderment, especially as many were unaware that they were chargeable until the day the bill arrived in the post. Women tell us that they receive invoices accompanied by letters and phone calls demanding money that threaten to report them to the Home Office, or even telling them that they will never be able to regularise their stay in the UK. These out-of-the-blue bills induce very high levels of anxiety and fear amongst our clients, affecting their physical as well as mental health. It is clear that charging for maternity care deters women from accessing not only maternity services, but GPs and other points of contact with the NHS for fear of being billed more money. Our data illustrates the many ways in which the NHS charging is unworkable. And ultimately, we want to call on the government to suspend NHS charging because of the negative impact it has on patients accessing care. However, whilst these regulations remain in place, we wanted to offer NHS trusts, senior management and clinicians practical ways to improve the application of these regulations and make sure that patients in the current system are protected as much as possible. So we saw a need to develop some guides that would support NHS trusts in better implementing the regs in the current form that they are at the moment. Our Access Guide, which was released last year, offers support and guidance for administrative and finance teams in NHS trusts when assessing chargeability and undertaking the process of cost recovery of maternity care. And our new guide, which is the Guide for Obstetricians, sets out some of the ways in which clinicians working with chargeable women can help mitigate some of the problems and barriers women face when accessing maternity care. We cover the basics, such as who is liable for charging, the charging rules of maternity care specifically, and what the exemptions are. But we also cover how clinicians can work with overseas visitor teams within NHS trusts, a clinician's role in advocating for their patient, and the role, or should I say non-role, a clinician should have in the process of invoicing, communicating, or managing a patient's debt. We understand the importance of a clinician's ability to build trust with a patient, and highlight in the guide that clinicians should not be asked by the trust to collect information to assess immigration status, other than to confirm that the woman has experienced torture, FGM, domestic abuse, sexual violence, or they may have been a victim of trafficking. One of our biggest issues we see is NHS trusts not being able to consistently identify women who have been made particularly vulnerable because of domestic abuse or sexual violence during pregnancy. And the safeguards that have been put in place through the exemptions do not always manage to safeguard the most vulnerable. Sometimes this is because women are reluctant to disclose violence in an NHS setting, or that women simply don't identify as being victims of domestic abuse or sexual violence until a process of healing and recovery has occurred. Sometimes it's the case that violence has been picked up as an issue by a clinician, but it does not then get communicated to the OBM team, meaning it does not translate into an exemption. Other times it's because the threshold of proof remains very high, and many women's experiences are perhaps discounted or are not necessarily picked up as adequate evidence. The complexity of the nature of domestic abuse, coupled with the complexity of the charging rules, makes for some additional support in its navigation, hence why we decided to try and produce these guides just to give a bit of additional steer in addition to the DHSE guidance, which is out there already and is very clear. We would love to encourage clinicians to share this guide and, of course, have any additional questions to contact us for more information or clarification. So please feel free to share the guide far and wide. It'd be really useful if we could get it into networks through the NHS, through RCOG, who will be speaking in a minute. And we will share a link to all of our guides at the end of the webinar via email. In the next few months, we also aim to publish another guide in collaboration with RCM that will specifically tailor to the experiences of midwives, which we know that the process with the booking process and all that kind of stuff is quite different. So we'll keep you posted on that. And thanks for joining us today, and I hope you enjoy the rest of the webinar. Thank you.
Thanks very much, Kat. I hope that you will find the guide self-explanatory. It's quite short, and I think Catherine's made a really good job of trying to make it accessible to those who are new to this issue. And we've been really glad to work with the Royal College of obstetricians and gynecologists in this work for over the period of the work, not just on this guide. And so I'd like to invite Emily Lewis now, who's the RCOG's Senior Policy and Public Affairs Officer, to give their viewpoint on the work. Thanks, Emily.
Thanks, Judith, and thanks, Catherine. It's really great to be here today to mark the launch of the this guide for obstetricians. And I just kind of wanted to say, again, straight away, just a massive thank you to everybody at Maternity Action, and particularly Catherine, for driving this work forward and producing these really important resources. I just want to say thanks as well to Brenda, who we'll hear from shortly, for being so generous with her time in putting into this guide and the previous one as well, and to our other members who've kind of reviewed drafts as well. It's all incredibly valuable. So I'm from the RCOG's policy team, and we work with the president and the officers, as well as our kind of wider membership across the UK, to understand the issues shaping women's health, and then to influence the UK governments and NHS to deliver positive policy change. So the college has been really clear that safe maternity care includes addressing the unfair and systemic differences in women's maternity outcomes and experiences. And we're also clear that this includes looking kind of beyond the health system to understand the policies and circumstances that are shaping women's health before they actually access care. And so this, of course, includes a focus on women who might be charged for their NHS care because of their migration status, and who we know are already at risk of poorer pregnancy outcomes for a wide range of reasons. And Catherine's talked about those just now. So yeah, much like Maternity Action, we've for a long time called for the government to to permanently suspend these charging regulations within maternity. And this has really been informed by what we hear from our membership and all the evidence that Maternity Action has been producing, and from their advice line as well. And particularly, again, as Catherine has talked about, about this threat of charging deterring women from accessing incredibly important and really time critical care during their pregnancy. So we published a policy position on this a couple of years ago, which I'll post in the chat just now. But yeah, so while the regulations remain in place, services do have an important role to play to kind of minimise that impact on care. And particularly ensuring maternity care is never refused or delayed, and that women feel as safe as they can while they're accessing these services. And so we hope that the guide that's published today will be a really, really useful companion for obstetricians kind of in their day-to-day work. So our president, Dr. Rani Thakur, couldn't be here today, but I'll post a link to what she said today. But she has said, we're pleased to continue working with Maternity Action to support women affected by NHS charging. This guidance will help provide trusts and obstetricians with accessible information on statutory requirements and how to manage maternity charging so that the impact for women is minimised. Maternity charging can act as a barrier to safe pregnancy for migrant women and must be tackled if we are to end the persistent inequalities in maternal outcomes in the UK. So going forward, we'll continue to share this guidance with our memberships throughout England through the channels that we have. And we will also be hosting it alongside the existing guidance on our kind of guidance pages on the website to make it as easy as possible for our members to find. Kind of more broadly in the policy team, we'll carry on pursuing the recommendations within our policy position on equitable care for migrant women, engaging with the government and parliamentarians on this issue, and continue to collaborate across the sector. So most recently, for example, this has included pushing for pregnant and breastfeeding women subject to immigration restrictions to be able to access healthy food through the Healthy Start scheme. But that's sort of slightly separate to this issue today. And we'll continue making the case for addressing these systemic barriers that migrant women are facing when we're engaging with the NHS and government strategies aiming to improve women's health and tackle health inequalities. And finally, I know there's a lot of members here today on the call or on this webinar. So if you have ideas about how we could be sharing this guidance more widely and promoting it, or you want to see us work on something else in this area that we're not currently talking about as much as we should, please do get in touch, and I'll put my email in the chat as well. So I would love to hear from you. thanks very much for having me again today. Back to you, Judith.
Thanks very much, Emily. It's great to hear the continued support of the RCOGE on this and the very clear statements made. You'll see that there are another couple of panelists, Mamie and Sarah, who are not going to do a presentation, but are here to help us with the Q&A session when that starts. So thanks to them. And we're now going to introduce our final speaker, Dr. Brenda Kelly, consultant obstetrician in Oxford. And Brenda will share some of her experiences. For those of you who are obstetricians, this is probably the speaker you've been looking forward to the most, to hopefully bring to life the role that an obstetrician can play in this very important issue. So over to you, Brenda. Thank you.
Thank you very much, Judith. And just by way of background, for those who don't know what the Rose Clinic is, it initially started as a clinic for women and girls with female genital mutilation, but in recent years has expanded to include holistic care and support for pregnant asylum seekers, refugees, and other vulnerable migrant women. I have cared for many vulnerable migrant women over recent years, and some of them I can help, and sadly many others come too late or have barely adequate maternity care. I'm going to talk about two cases. Obviously the names have been changed. By the time that Eve presented, for example, to the emergency department a few years ago with severe abdominal pain, vaginal bleeding, she had severe high blood pressure with renal impairment. A short time after her arrival, Eve gave birth to her stillborn little girl, who she called Grace. And I certainly remember that day, and I don't think anyone in the department that day, from porter to doctor, was left untouched by Eve's anguished cries as she cradled her dead daughter. Now, chatting to Eve after that event, she thought she had been 7 months or so into her pregnancy, but using her words, being without papers, when the pain started a few days prior to her arrival at ED, she had sought advice from an auntie in the community rather than a midwife or doctor. She had been afraid to come to hospital. She had no money to pay for her care. She didn't have the right papers. She was deeply worried that the hospital would report her to the authorities and that she would be detained and deported. So she had two major concerns. I'm really privileged to work with Maternity Action, the RCOG, in this particular area of work. I mean, a fear of charging and fear of being reported are two of the biggest barriers to safe maternity care for this cohort of women. And we're launching this short guideline to help you work with those women who may be affected by charging, to work with your midwives, your local overseas visitors teams, and I'll outline how I do that in Oxford shortly, and also bringing into that MDT working your safeguarding teams as well. And I think the key take-home message here is that we can't afford to delegate this responsibility if we're truly committed to addressing health inequalities in this in maternity. Women such as Eve are amongst some of the most vulnerable women we care for and at greatest risk of poor outcomes in pregnancy. Many of the women that are potentially chargeable have fled to this country to escape war, honour-based violence, forced marriage, FGM, and other forms of gender-based violence. And many will lack the knowledge or wherewithal to know how to register what might be a reasonable asylum claim. Others sadly have been trafficked. Some have overstayed visas. Some have fled domestic violence and no longer have the right to remain under a spousal visa. And these women are part of the population that you will be working with in the UK, wherever you're based. And importantly, contrary to what, the Daily Mail and other papers or those who support the hostile environment might portray, these women are not health tourists, they're desperate. And accessing care during pregnancy will help keep them and their babies safer, and that's a well-established fact. It also helps them access care with other things, help with other things that they may be in need of. In Oxfordshire, our emerging group of undocumented women are from the East Timorese community. And now, as a former Portuguese colony, many initially came to the UK through the EU migrant route and legally settled in the UK. But those who've come afterwards in this sort of brave new world of post-Brexit, may have fallen foul of the complex rules around settlement, and lacking settled status then become undocumented. And with our East Timorese community, very few speak English. The majority work in low-paid jobs and experience conditions of poverty and destitution. And for us in Oxford, they represent some of the most vulnerable women in our care. So it's important that wherever you work, that you do have an understanding of the communities of women that you look after and where their particular vulnerabilities may be in relation to charging. And I agree absolutely 100% with the college stance on this, with Maternity Action stance, that is morally reprehensible at a time when we're being instructed to tackle maternity health inequalities, that we continue to charge those most at risk of harm. And I think it's important to understand that our overseas visitors teams are not sort of ogres in management. They are legally obliged to seek out those who are chargeable and to produce the invoice and to chase the debt. But they don't possess the skills that you have in relation to being able to ask questions around potential exemptions and to make inquiries around potential destitution. It's outside their scope of work, and that's where we come into the play, in that we can actually help them understand that and support them better in the work that they're doing. So how can we use this guide in practice? So I'm going to give you an example of a recent case which has led to the sort of us in the Trust developing a way of working together with our overseas visitors team. So Naomi, in this case, was unbooked until she presented to the maternity assessment unit at 20 weeks with vaginal bleeding. Now, she was on a visitor's visa to the UK to visit her British husband. During that first admission, she disclosed a previous history of term stillbirth and was therefore transferred to high-risk pregnancy care pathway. She went on to have recurrent vaginal bleeding and abdominal pain and several more hospital admissions. And her team were surprised, as you can imagine, when Naomi asked for a fit note to fly back home. And she was citing that the reason why she wanted to do that was to be with her extended family. Now, aware of the poor health infrastructure in her country of origin, her obstetrician explained the concerns regarding the risk of abruption and the risk of stillbirth, and also deemed that with recurrent pain and bleeding, that she was unfit to fly. Now, Naomi remained living locally, but she defaulted from antenatal care. She did not return her midwife's calls. And at 32 weeks, her midwife doorstepped her to sort of inquire why she was defaulting from care. And Naomi then explained that she wanted us to stop giving all maternity care to her, all pregnancy care, because she couldn't afford the bill that she had received. And her belief was the bill had come from us in maternity. She also disclosed that she had no means to pay for the bill, and that her husband was in significant debt, and that the stress of that debt was putting a lot of strain on the marriage, with sort of an allusion to some potential domestic violence as well. So she asked if it was possible just to come to hospital to have her baby. Now, knowing of the interest that I have in NHS charging and the clinic service that I run through the Rose Clinic, the team discussed Naomi with me. And in the first instance, I spoke with the overseas team to determine what had actually been presented to Naomi. And cognizant that maternity care is deemed as immediately necessary, the overseas team had not actually asked for any money up front, as is the practice and the guidelines, but simply had informed Naomi that she'd be liable for charging as she was on a visitor's visa. And an estimate of the cost of her care was given, with the option of paying if she wished in installments after the baby was born, but with the option to start any payments that she wished or was able to make during pregnancy. Now, when I explained the background situation to our overseas team, that we, in essence, had removed her ability to return to her home country because we hadn't deemed her fit to fly, but also presenting the real human side to this story, that this is a woman who had experienced the tragedy of a previous term stillbirth, and also given her high risk picture in this pregnancy, that we were deeply fearful that she would experience an outcome quite similar to Eve in relation to stillbirth. they agreed to pause all further communications with Naomi. When I was explaining the challenges around her husband's debt, they also were willing to consider that we could explore potential exemptions, but also explore whether she was manifestly destitute and therefore unable to pay. Now, we shared that information with the couple. They agreed for a referral to a local charity in relation to their debt in order to document their debt, but also help them with debt management. And her husband consented to full disclosure of his debt and financial situation to the Overseas Visitors team. Now, with agreement from the Trust, the Overseas Visitors team themselves cannot just cancel debt, but working with the finance team, it was recognised that Naomi would be unable to pay for care, that her fear of care was jeopardising her well-being and also the well-being of her child. And that although the record of debt would remain on her file, the Trust used their own discretion to write off that debt. And Naomi went on to have a healthy baby girl 4 weeks after this. So we as a team felt that this was a near miss. We were very mindful of what had happened previously with Eve. But had we not had the knowledge or advocated for Naomi, the outcome might have been very similar to Eve. And following on from that case, we in the Trust decided to formalise that arrangement between the Overseas team and maternity with monthly meetings for about 30 minutes each month. And sometimes meetings don't even last 30 minutes. So the Overseas team can discuss who's flagging on their system. So the Home Office can flag women with sort of dubious immigration status, or those who are known to be undocumented and potentially liable for charging. And this enables us to be proactive in supporting the women's maternity team to explore exemptions, but also the financial situation as well. It also helps, and this is what the Overseas team say, it helps them understand the population locally. It helps them understand the person behind the hospital number and the invoice number. And it enables bi-directional learning too, because I now have a great understanding of their challenges as well. We've also worked towards improving their knowledge about what those exemptions are and the inquiries we have to make, and agreed a way of recording those into the maternity records such that the Overseas team can access that when someone flags on their system and determine whether that would represent an exemption as well. So I'm just conscious of time and I don't want to eat into the vital sort of video and also the discussion, but what would be the take-home messages if I were to give some today? It's please don't put this notion of NHS charging and our responsibilities onto that sort of too difficult to deal with pile. Please read the guideline, understand the importance of your role and your advocacy. And I would say that being a consultant obstetrician, you do carry some clout, as it were, with trust management as well. We were able to advocate and we should be using our voice and our platform. I'd also ask that you're professionally curious. Get to know your local communities, get to know where their vulnerabilities are. When you see incidents coming through in relation to unbooked women presenting in labour, unplanned home births, ask the question, was that happening out of fear of or actual charging? Was that a consideration? And with those women who have frequent non-attendance, substitute DNA with CNA, could not attend, or even TA, too afraid to attend. And above all, keep the woman at the heart of the discussion, remembering that exploring those exemptions and exploring whether there is destitution, you're not only going to help in relation to NHS charging, but you could help her access sort of the help that she needs beyond just NHS charging. So with that, I'll hand back to Judith. Likewise, I'll put my email in the chat if there were any specific questions to follow up if there's not time to ask them directly. And I really do hope you make use of the guideline. Thanks very much, Judith.
Thanks very much, Brenda. I hope that the attendees have found that really useful. Thanks for giving it some real life. That was really needed. And on that note, we're going to hear from a woman who was kind enough and brave enough to talk about the impact of the charging regime on care in much the same way as Brenda's been saying, but obviously from her own experiences and that of other women that she's worked with in an organisation that helps women sort of speak up for themselves and on behalf of each other. So Lauren's going to now share her screen, and we'll be showing a short film. It's three and a bit minutes long, I think. And here we hear Mary's story.
I arrived in the UK in November 2019 from Nigeria. I was not the first person who opened the letter. It was my ex-partner who saw it and opened it, and he read it. He didn't say anything to me. He just handed me and said, "You have a letter." And when I opened it, I was like, this is a bill. I was really scared because the bill was much, 4,000 plus. I was really scared because I didn't know where to start from. If I could get a bill of 4,000 for a miscarriage, I was worried about how much I was going to get for having a baby. I think it was set for me to pay £5 a month. And then my social worker said, it's not going to work because they don't even give me money all the time. Sometimes it takes 3 weeks before I get £100. Sometimes 2 weeks. I have to call them, chase them. The money was not regular. So there was no how I could go into the hospital. I had no bank account then. So I have to spend like £5.30 to go there and pay £5. A couple of times I was feeling unwell. I can't even call the GP because I'm really scared of anything that has to do with hospitals. I don't want any more bills on me. I don't want any more debts. And for you having that kind of debt on you, you being alone with a baby, you don't even know what the future holds. Sometimes I don't even want to think about it because it gets to me mentally when I think about, I just tell myself, okay, calm down. It's temporarily off. Think about the next step before you worry about it. But the truth is, you can't really get it off your head because it's there and it's in your name. It's in my name, it's there. I can't really get it off my head. I think about it all the time. And whenever I try to make plans for the future, it's always part of the plan. Like, okay, I have this debt to pay off. So it's not really easy thinking about you having that much on your head without help.
Thank you. I think it's fair to say, somebody else will know better than I do, but I think it's fair to say that the bills are significantly higher than that now, and she's right to say that the bill for actually having a baby would be much more than that. I think we're talking in excess of £10,000 now, unless I've got that wrong. Okay, so we're on to the Q&A session. I can see from a little button at the bottom that we've got 3. I saw, oh no, we've got 1 question and 2 bits in the chat. Catherine and Brenda have both given their email addresses for further questions. It might be that questions arise more when you've had a look at the guide. And thanks, Emily. I can see that you've put in the policy position. On the Q&A, which was posted by an anonymous attendee earlier on, refers to the tourists attending the UK misusing the public funds and taxpayers' money in high-risk pregnancy with poor outcomes. I mean, I think that Brenda talked a bit about the high-risk pregnancy, and that there are several reasons, I think, that several factors that can give women high-risk pregnancies, but certainly some of the women we see, it's because they haven't had the care earlier on in their pregnancy. But there might be other reasons for that. I mean, I think we've not talked in a great detail about the policy position on charging generally, because that's not something that we're focusing our advocacy attention on right now. We, like the RCOG, as Catherine explained earlier, we don't think this charging regime is workable. And I think there are other organisations that work more widely with other patients who are denied care who would say similar things. I think our policy position at the moment is that we're trying to work with a system to ensure that only the people who are able to pay can pay. And really, it's about that distinction of whether somebody's living here or not. These are women who are living here in our communities. Some of them for many years, some of them will have children who are British, will be able to regularise their status at some point. But I suppose it's worth saying that in order to regularise your status, if you're undocumented, you need both legal advice, which you won't usually get for free, and you will have to pay to make those applications. And so if you think about a family, that's not something that can be done at an instant. So I think that we're focusing on the risks to those women and the health risks to those women of being fearful to access care or having charges placed on them that they simply can't pay. I don't know if any of the other panelists want to offer any additional information about that.
I would just say as well, I mean, the question that the attendees put is one that I get asked quite a lot in terms of about health tourism. And I'm very conscious. I mean, I'm in agreement around NHS charging for maternity care and that it should stop. But I think we should also consider numbers. I don't have the precise figures in front of me, but I'm just reflecting on the cases that we would have seen come through the overseas, the sort of MVT around the overseas visitors team, that the overwhelming majority of women who are deemed as chargeable are falling into the categories that I've described around destitution, overstayed visas. They're not coming here specifically for their maternity care. They have not got on a plane in West Africa to come here to deliver triplets. That, you know, I am also aware that some people who are not ordinarily resident in the UK, who have lived here previously, have returned to the UK and been chargeable for care. So I think that it's important that health tourism is overplayed in the discussion around NHS charging, and I would say particularly in relation to maternity care. I don't know, Kat, if you want to come in, because I think Maternity Action, you deal a lot more with this issue.
Yeah, I think that our MCAS team will probably want to chip in as well, but I'm of the understanding that the profile of the women that usually contacts our service are women that have lived in the UK for a number of years, have had probably more than one child here already, and wouldn't really put them in the category of health tourism, have probably come here fleeing persecution in the asylum system, whether that be refused or not, or in a position of destitution as a result of leaving a spouse who may have given them the regularisation that they previously had, and then may have fallen out of regularisation in that way. So it's not really something that we come across particularly as this kind of health tourism idea. I don't know if MCAS want to chip in anything extra above that.
Yeah, no, just to reiterate that basically is that that's just not our experience of the clients that we see, and that it's all interlinked with hostile environment policies more generally, that if people can't access care because of their immigration status, and you know, we see many women who have been trafficked or have been victims of domestic violence or abuse. But yeah, the health tourism aspect is a question that comes up a lot, but it's just not it's just not what we see in our 600 cases of the year. And where the people are chargeable, and maybe here on shorter term visas, are often willing to pay, but it's just so labyrinthine trying to get a repayment plan in place, and it goes into an area of debt regulation that we obviously can't advise on.
Thanks very much. We have another question in the chat, which is around generally mentions the hostile environment and asks if the Royal College of Obstetricians and Gynecologists and Maternity Action and others are working more generally to discuss with government around the hostile environment and specifically charging. It isn't something that we've discussed with this new government yet. I think we're trying to work towards both making sure that those women who are currently experiencing charging are helped individually, and that we're producing these guides, as Catherine said earlier, to help clinicians know what their role is in that. It isn't that not all of the women that we see will be exempt, and we work with them to try and resolve their situation, as do others. I think it's something that we will want to discuss at some point, not least because we really don't think this situation, the situation as it is now, is workable. I think there are so many difficulties with it, so many evidential requirements that often can't be met. And we are in discussion with other organisations who are working on this. So I hope that reassures you that this issue isn't something that we're not simply waiting to see women and just do the charging work. Catherine works in the policy team here at Maternity Action, and that's something that we work on together, is seeking opportunities to both raise awareness, such as speakers have done today, but also think about what arguments we can use with the government and what alternatives might be suggested. But it isn't something that we've done with this government so far. I don't know, Emily, if it's something that you want to comment on.
Yeah, no, I think very similar to what you're saying there. And I think the thing for the college, we do speak to the government and to parliamentarians fairly frequently, and I think the link that we're always trying to make is this link between women's health outcomes and the government's ambitions, as Brenda said, to reduce health inequalities and deliver safe maternity care for everybody. But then these contradictory policies, which we see have harmful impact on women's health outcomes. But yes, as yet, not much with this government. It's a tricky, I think, policy context at the moment. Yeah. So, and again, as I said, it's the other things that can improve women's health, like access to care, and things like access to the Healthy Start scheme, and other ways that can provide support. So I guess that's our focus at the moment. Yeah.
Thank you. And I think it's, there's a lot of new parliamentarians, and actually those with whom we have spoken are often surprised to hear about it if it doesn't come to the notice through their casework. It's something that's a bit of a hidden issue. Yes, thank you. Tony has also put in the Q&A that actually in Lewisham they've been working with the trust and developing a better practice guide, and we're certainly aware of that. I think Catherine, you were the one who went to the launch of that. We're very impressed with some of that work. And so yes, oftentimes actually in influencing individual trusts, either from a campaigning point of view or, as Brenda has spoken about, talking individually to those managers and trying to educate them into sort of the issues that they're dealing with, that this isn't just a matter of bills, of producing bills. Brenda's asked Tony, I don't know if you're able to reply, or if Catherine can, because you went to the launch of this report, if their guide is just about maternity or wider on health.
Yes, I attended the Citizens UK event. I think it was a couple of weeks, and I met Tony. I think I met you there at the event, which was brilliant. And the guide is a more general guide, I think, the one that's been produced by LMRN and Citizens UK, I think, which is excellent. And we'd love to keep kind of in touch with you guys about what kind of campaigning things you're doing in Lewisham and how we can kind of input into that process as well.
There's another comment in the chat which is around hostile environment, and I think people are rightly making this connection that this is about service delivery organisations being asked to ensure that people who are not ordinarily resident in the UK don't get access to other services. I mean, obviously we think that health and maternity health in particular is probably the most extreme of these, but we know it's happened in lots of areas, such as, you know, landlords being asked to check people's immigration status before letting homes to them, and, you know, banks, driving licenses, etc. And this was a policy of the previous Conservative government. This government doesn't use that particular language in its policy development, but certainly we've yet to see any big sort of overturning of a similar approach, and those laws still remain in place under this government. So no, thanks for your comments. I think we've got comments in the Q&A and a few bits of interesting information and contact details in the chat. Emily, thank you for putting the guidance in there, and as Catherine said, later on we'll send a link via the same link that you used for the Eventbrite, for signing up to the Eventbrite. So you don't need to do anything. You should get something in your inbox to access the guide, and it's going to be on our website and social media, etc. So we've reached the end of the time that we've allotted for this. So just by way of wrap up, I'd like to thank all the speakers who've spoken today, to all you who've attended, particularly to those of you who are providing care to this group of women who are made particularly vulnerable due to their circumstances. And I do hope that you're able to use the guide, share the guide, and give it practical application in your day-to-day work. So thanks very much for attending today, and I wish you all a good day.
Thank you. Bye.
Bye. Thank you.
Thank you, everyone.
Bye.